I'm Dr. Bowers, and I will be talking about the osteopathic standing and seated flexion tests. Both of these tests test for motion at the sacroiliac or SI joints, but the standing flexion test is more specific for how well the ilia move on the sacrum, also known as iliosacral motion, while your seated flexion test is more specific for how well the sacrum moves under the ilia, which is known as sacroilial motion. When the patient is standing when doing the standing flexion test, that allows for influences from the legs and the innominate to affect the test. But when you have them sit down in a position that locks out the legs and the innominate, then those are no longer influencing the motion at the SI joint as much. So we say that it's a positive test if, when the patient flexes forward, the posterior superior iliac spine, aka PSIS, moves farther cephalad. And what that indicates is that there is dysfunction on that side at that SI joint. And if it's a standing flexion test, it means that the dysfunction is coming from the ipsilateral innominate or lower extremity. But if it's a seated flexion test, it indicates that the somatic dysfunction is at the level of the sacrum at that side or somewhere else higher up. Normal dysfunction-free SI joints should allow for some glide between the sacrum and the ilia. When the torso is flexed forward, the sacrum follows it, gliding beneath the ilia. When there is no more room to glide, the ilia will get dragged along for the rest of the ride. When an SI, sacroiliac joint, has dysfunction, the ilium and sacrum lose some or all of their ability to glide over or under each other. Regardless of whether the problem is with iliosacral motion or sacroiliac motion, the result will be the same. In this case, when the sacrum moves forward like it does in a standing or seated flexion test, the posterior ilium will be forced to move more cephalad on the side that has SI joint dysfunction than it normally would. If only one SI joint has dysfunction, then there will be asymmetry. The side with the PSIS that moves more cephalad is the positive side, aka the dysfunctional side. Let's imagine a case where the left SI has dysfunction. The two hands in the lower part of this photo are playing the parts of the ilia. The pink dots represent the PSISs, and we'll talk more about them later. Note the positions of the pink dots when the spine is not flexed, like in this picture. They seem relatively even here. Then, in the second picture, notice where the pink dots are once the sacrum has fully flexed. The left PSIS was dragged more than the right PSIS, so we would say it is positive on the left. If this occurred during a seated flexion test, it would be a positive left seated flexion test. If it happened with a standing flexion test, it would be positive standing flexion test. When performing either the standing or seated flexion test, you want to hook your thumbs under the PSISs. It is easier to feel if there is no material in the way, but you definitely want to make sure your thumbs are not on a shirt, or else the shirt will yank your thumbs off the PSISs when the patient leans forward. Let's watch how you might palpate for the PSISs.
So the first thing you're going to want to do is find the PSISs, and when you're starting out, it can be helpful to first find the iliac crest, which are going to be located at the waist. So I press inward and down, and I feel that there is a bone inferior to my hands. And I just walk along the edge of that crest until I can't quite feel things anymore. So the PSISs, I usually do a circular motion to find them because they're a little nub sticking back at you, and so it's easier to find a little nub when you do a little circular motion. And sure enough, he has one right here. And so I want to make sure that I hook right underneath it. And on this side, it's a little bit higher. So already I can see that there's some asymmetry with his left PSIS being inferior to his right PSIS. And I'm hooked underneath like this.
For the standing flexion test, you're going to want the patient to be standing without any shoes on. Their feet are flat on the floor, about 6 inches or so apart. For the seated flexion test, instead, you'll have the patient sitting on something that doesn't have wheels and is going to be nice and secure. And ideally, their hips and knees are going to be flexed to about 90 degrees, and they're going to have both feet flat on the floor. This is going to be what helps lock out those lower extremity and innominates so that they do not affect the test. You want to be kneeling behind the patient so you are at eye level behind the PSISs. Once you've hooked under the PSISs, note their relative position to each other. Are they at the same level, or is one higher or lower than the other? Clearly, the right PSIS is higher than the left in this picture. Then you'll ask them to stand or sit up straight, then to bend forward while you keep your thumbs pressed against the underside of the PSISs and allow your thumbs to go along for the ride. You want to feel how much the PSISs move. It doesn't matter which one ends up being more cephalad at the end of the flexion. It matters which PSIS moves more cephalad as the patient is flexing. So for this patient, if their left SI joint is positive and has an issue, it still might be more inferior than the right at the end of flexion, even if it moved more because of how much more inferior it sits when upright. Now let's watch the standing flexion test in motion for this patient.
Stand up nice and straight. Bend forward like you're going to touch your toes. And come back up.
This video showed a positive left standing flexion test. Let's watch it again, and this time pay attention to how the right thumb moves smoothly and gradually while the left thumb seems to almost get jerked upwards and then drop back down again when the patient straightens back up.
Stand up nice and straight. Bend forward like you're going to touch your toes. And come back up.
A video showing the seated flexion test would look pretty much the same, except you would have positioned the patient in a seated position as previously described. So, some last points. Standing flexion test allows for the influence of the legs and the innominates. So when the standing flexion test is positive, you should be thinking about and looking for somatic dysfunction in the ipsilateral innominate or lower extremity. If your seated flexion test is positive, then since you should have positioned them so the legs and the innominates are locked out, that means you should be thinking about somatic dysfunction in the sacrum or somewhere higher up. Since neither of these tests are very specific for actually it being the innominate that has the dysfunction or the sacrum that has the dysfunction, there's other tests that are more specific for you locating the issue to those areas. So instead of the standing flexion test, or in combination with it, the ASIS compression test is actually more specific for ilium dysfunction because your hand is on the ilium and it is moving it against the SI joint. So it trumps any of the standing flexion test finding when you're talking about the innominate. Seated flexion test, your sacral spring test, you're right there, you're pushing on the sacrum, you're getting a sense for how well it springs, and you can combine that with the Sphinx test, and you can combine that with other landmarks of the sacrum and get more specific diagnosis about the sacrum than what the seated flexion test gives you. This is why I and many other DOs do not actually use either of these two tests when diagnosing the innominate or the sacrum. Yet, these tests are useful and you can use them clinically for other purposes.